to play. So, beginning with today's IC, I would like to invite my first speaker, Dr. Arundhati Tamuli, a prolific phacosurgeon and a cornea consultant from Assam. She is the Chief Medical Officer of Lions Eye Hospital, Dibrugarh, and she heads the cornea department of Apeksha Hospital, Dibrugarh. She'll be speaking on pearls for a more stable anterior chamber. Over to you, Dr. Tamuli.
Thank you, Jashi. I'm Dr. Arundhati. So today I shall try to simplify the principles to maintain a stable anterior chamber in phacoemulsification. But before that, I want you to realize that phacoemulsification is not a static process. It's a dynamic process. A stable anterior chamber doesn't just mean being still. This is something you can imagine of a tightrope walker who always try to balance itself by doing slight movement in order to achieve its goal. Similarly, in phacoemulsification, we maintain the stability of the anterior chamber by balancing the fluidic system. So in phacoemulsification, the fluid game of phacoemulsification, it has three players: the infusion, wound leakage, and the aspiration. The infusion brings fluid into the anterior chamber through the irrigation line, whereas the other two players, the wound leakage and the aspiration, it take out the fluid out of the anterior chamber. So to maintain the balance and the stability of the anterior chamber, the fluid entering into the anterior chamber must be equal to the fluid exit, so that we can have a normal pressurized stable anterior chamber. But if we see practically, it doesn't happen in an absolute term because small amount of microfluctuation always remain. So let's see what happens if the infusion goes high. The intraocular pressure will be raised. So at that time, we'll see the anterior chamber will remain full with a high IOP, but clinically it won't be evident. But only when there is excessive overpressurization, we'll see there may be jonular stress, aqueous misdirection into the vitreous, and very rarely we may get wound leakage. What if reverse happens? If the aspiration goes high and cannot be compensated by infusion, then we'll get shallowing of the anterior chamber because of the low IOP, and which is clinically evident. Similarly, the same thing happens if there is an excessive wound leakage. We'll get an unstable anterior chamber. But what we have observed, like whenever the infusion goes high, clinically we won't observe. Clinically the things will not be observed. But whenever there is an excessive exit, like excessive aspiration or wound leakage, we'll see it clinically. We can see there is a shallowing of the anterior chamber. So here I want to emphasize that we cannot absolutely avoid the mismatch in a rapidly changing scenario of phacoemulsification. Our aim should be to make it as minimum as possible to have a surgically stable anterior chamber. Why I am saying surgically stable anterior chamber? Just I want to ignore the microfluctuation which always remains. So this is a typical phacoemulsification setup in a peristaltic machine. So here we can see what happened exactly. The fluid first travels through the irrigating line, then reaches the phaco handpiece, then through the irrigation port it enters into the anterior chamber. And from the anterior chamber, the aspirins are taken out because of the revolving nature of the pinching wheel. So here the RPM of the pinching wheel will determine how fast the fluid will drag out of the anterior chamber, and this is called the aspiration flow rate. The same thing will determine how fast the vacuum rise, the suction pressure will build up. In contrast, in Venturi machine, there is no revolving wheel. So here the compressed gas, it creates a vacuum, and this vacuum drags the fluid out of the anterior chamber. So let's see how we can minimize this fluctuation level, how we can make the stable anterior chamber stable by doing some modification. Number one, what we can do, we can increase the fluid height. So by increasing the irrigating fluid height, the force of fluid inflow will also increase, and this in turn causes raise in the intraocular pressure. And this high in the anterior chamber pressure, it's sufficient to resist the sudden fluctuation which usually we get in case of occlusion break. Second thing, we can modify the exit route. Like if we can reduce the phaco tip size, we can reduce the exit, like we can reduce the aspirant. Second, if we make an incision which corresponds to the size of the phaco tip sleeve, we can reduce the leakage, because when the leakage will be more, there is more chances of shallowing of the anterior chamber. Third, in case of peristaltic machine, we should keep the RPM as low as possible. This is because this determines the AFR. So when the AFR is raised, all the events that takes place in the phacoemulsification, they will also go in a faster space, whether it's a vacuum, it's a rise time, or the surge. So it's important that we should keep the AFR in a minimum level so to avoid any untoward accident. But in Venturi, as we don't have any RPM, it's the vacuum limit which we take into consideration. The vacuum limit is something which prevents the vacuum to rise beyond a preset level. Because if there is more vacuum, there is more chance of fluctuation rise, especially after a sudden occlusion break. So these are the modifications which we can do to maintain the stability of the anterior chamber. So let's see what the innovators are doing in this newer generation machine to reduce the fluctuation to a micro level. So first is the positive pressure infusion. The BSS, here they have earlier, like air was insufflated into the bottle in order to create a positive pressure. But nowadays, the many phaco machine, they have a compressed bottle. This compressed bottle are guided by a sensors that senses the intraocular pressure in the anterior chamber, and thereby it's maintain the IOP to a desired level so that surgeon can work comfortably in any scenario. Second, replacing the rubber tubes which are very malleable and compressible by replacing the rubber tube by a silicone tubes, which are the rubber tube are considered very malleable and expensive. So any fluctuation, if it's there in those rubber tubes, it can be transmitted easily into the anterior chamber, so thereby affecting their stability. Third, there are machines which have got enclosed peristaltic machine in the cassette, and these are found to be very effective in controlling and dictating the fluidics in the anterior chamber in a more precise way. So there are lots of innovations that have been done in many phaco machines, like fluid bypass port in the phaconeedle, surge suppressor device, and there are surgeons who use additional infusion port, like by using anterior chamber AC maintainer in order to stabilize the anterior chamber. So at last, I would like to say every surgeon has its own unique surgical style. Understanding the fluid game to the core will let one tune the machine to his style of surgery. We then don't have to memorize the phaco parameters as a company set confusing data. Thank you.